Hello, everyone. My name is Kelly Wark. I'm an infectious disease physician at the University of Kansas, and also I work at KDHE in the Antibiotic Stewardship program. I'm the lead for that, and then the subject matter for antibiotic resistance. And so I've done quite a bit of work through both the my health system work, clinician work, and also through the state side. And so I was going to talk about that towards the end. But first, I was going to go over the kind of what are the national and statewide antibiotic trends that vary by types of people or demographics and also conditions. And also, there's some literature around. There's quite a bit of variability in prescriber differences too. And then briefly, I was going to talk about some of the available resources that we can use actually to kind of build stewardship and interventions or incorporate that into our stewardship programs or our quality programs. So so the National Academy of Medicine, formerly what used to be the Institute of Medicine, it describes equitable healthcare, as we know, as the one of six domains of healthcare quality. So we think a lot of quality, but we should also think that this is essentially quality. But as it pertains to antibiotics and antibiotic stewardship, there isn't, a good amount of literature suggesting what are the differences. Are there differences in prescribing that's happening to different people or by different people? And certainly there's even less, essentially, there's really no information on those drivers. So what is really that perpetuate these inequities? But this is very important because what we strive to achieve is that we get equitable access to medicines across the board. And so this is maybe a new term that you guys might have heard of called pharma equity. So meaning we have access and equitable dissemination of medicines to so that everyone has access to them. So, and how are these differences in antibiotic prescribing important? So, certainly, if you are someone that is prescribed more antibiotics, you might have an increased risk of antibiotic resistance or those adverse events from those antibiotics. Or if you're not diagnosed with an indication that needs an antibiotic compared to someone else, then of course you might suffer the consequences of not getting that antibiotic. There's certainly important ramifications of looking into our antibiotics for this. This is a pretty good kind of a systematic review, or they called it a scoping review, that came out last year by some of the researchers at the CDC that's in the stewardship program. And so they kind of formed this, they did a review of all the literature out there regarding antibiotic use and antimicrobial and also antifungal and antiviral, but really it's mainly antibiotic use. And what do we know out there? They came up with this kind of model, this kind of based on the ecological framework. And so, of course, there's many, many factors that contribute to differences in antibiotic prescribing. So we can think of things on the national level, the state level, such as like we just heard that we aren't in, Medicaid expanded state. Those policies that impact people's access to care, safety net, clinics, hospitals, that kind of thing, structural inequalities, and then there's also the community aspect. So, like a state like ours, where there's a lot of rural areas, medically underserved areas, people with not access as much as either whether it be pharmacy access or clinician access. There's so many other things that go into a community, including that certain groups of beliefs, their cultural norms, how they interact with clinicians, how perhaps they you know, uh, so for instance, in Kansas City, there's an outbreak of TB. And so this is a population that having difficulty kind of that distrusts the medical community. So there's all these other kind of components that factor into that within the community. Certainly the healthcare, and that's the big one that we focus on, the healthcare and the individual level. And so just to basically emphasize that this is a multifactorial stuff that goes into the differences in health, like all these different kind of health things, but also antibiotic use and antibiotic resistance. So this was the systematic review. It was actually, so they found 61 studies that qualified for this that have looked into antibiotic prescribing by some kind of demographic, whether that be race or ethnicity or gender or extremes of age, region, stuff like that. The bulk of them are the outpatient side. So around 90% of them actually are in the outpatient world. There was like a few, I think three in the dental clinics, nine in the ERs, and 43 in primary care. So the area actually, surprisingly, this is almost like kind of opposite as what a lot of clinical research is that we actually have a lot less information on the inpatient side. There actually, and I'll talk about it, there's really only been one study that's looked at differences in antibiotic prescribing in the hospital setting. So, first, like I mentioned, I'm just going to kind of go over what is out there in the literature. It is fairly sparse, but there is some interesting trends. And I don't think so. Starting off with age, I don't think this is a big surprise that there might be differences in extremes of age. So, the really young and the really old tend to be prescribed more antibiotics. There was a study in Kentucky where they looked at Medicaid patients or kids under 18 on Medicaid, and they found that especially those that were 0 to 2 years old compared to those that were 10 to 19 were especially more likely, 39% more likely to get antibiotics. And I think this makes sense too, that the very old, with more comorbidities, we perceive that maybe they are sicker and that they would be more apt to get prescribing. And indeed, that is pretty much what the literature shows, that the older people do tend to be prescribed more. So there surprisingly isn't a lot of information on gender. Pretty much all the studies that have looked at this, they tend to show that females are prescribed more antibiotics across the ages. So regardless of whatever age it is, females tend to get more antibiotics than males. And this is based on biologic sex. So there's actually been essentially no studies that have examined like their gender identification or sexual orientation, or people with transgender and antibiotics. There's essentially been no studies that have looked into that. This may be related to certainly females do tend to have more healthcare exposures. So is this a reflection of they're just accessing, they're having more visits? Is maybe a little bit of a bias towards that group. So, race and ethnicity. So, these studies looked at a variety of different respiratory conditions. So, respiratory conditions that would necessitate antibiotics. So, that included pneumonia, acute sinusitis, otitis media in children, and strep pharyngitis. So, they weren't looking at upper respiratory viral infections. These are all conditions that, generally speaking, should have got antibiotics. And this was a nationwide study with the Vizient, so all those hospitals that are involved in that network. So it was over 3,000 hospitals and it was claims data. And they found that Black children were actually 28% less likely than white to receive antibiotics. And again, these are conditions that would necessitate antibiotics. They varied by condition. So, for instance, the most dramatic difference was the acute otitis media and the strep pharyngitis, which is quite bizarre because it's the case definition for strep pharyngitis is that you have you get a strep screen. So quite odd in that they would be prescribed so much less. Pneumonia actually was pretty equal. So there wasn't a lot of differences in pneumonia between Black and white kids. There was another study, Gerber and colleagues, where they actually looked at the prescribing by clinician, and they checked to see is there differences in how these prescribers are prescribing based on different groups. So for the same conditions, did they prescribe pneumonia to this group? Was it a different type of prescribing habits that they're doing to this group? And actually, what they found that the same clinician, they were 25% less likely to prescribe antibiotics for the same condition to a white or to a Black child as a white child. And these, again, same indications. So quite unusual. And that was also a national, like a big amount of. I think this one had something like two or 300,000 encounters. So a lot of encounters. This wasn't just like a small group of people. They didn't really break down on like type of clinicians or anything like that. It was just kind of a national type of cohort study. Um, Another thing that's been found, and this is in particular to respiratory conditions, is that They Black, and also there's been some study that Hispanic children for respiratory conditions are less likely to prescribe broad spectrum antibiotics. So instead of giving them amoxicillin, maybe they got augmentin instead. But that would be less likely to be prescribed for a Black child than a white child. So in that same study where they looked at all those clinics, those pediatric clinics, there was another one, this one by Gerber, where they looked at they checked this out by clinic. So they looked at 25 different pediatric clinics and all these different conditions. They didn't really label it on their graph quite well, but these are all the clinics on this forest plot, and you can see the ones that tended to be under the one. Those are tending to prescribe less for Black kids compared to white kids. So you can see in all of these 25 clinics, it tended to be across the board. These were in clinics which were in academic centers, they were in urban centers, they were rural. So this was pretty, this is a pretty consistent finding. And this encompassed over 200 clinicians too. So there was another study, this was also in children, and this was specifically was for pneumonia, and they actually found that, so kind of, I put this under worse prescribing, and that Asian children actually, when they were hospitalized, they were 5 times more likely to get broad spectrum antibiotics than kids that were Asian. They didn't, again, this is kind of a cohort study, a very large national study, so they didn't go into like none of these studies go into the factors of why this is happening or these drivers. They're just finding that there's differences here. And then they did actually find that Hispanic children were, for pneumonia, were 2 times more likely to be prescribed antibiotics. Yeah. So the question was for those online, is this based on claims data or actual like prescriptions? And so this one, I believe, well, the Gerber one before was based on the Vizient data. So that was like, they have pretty good data into the demographics that is in that group. So for instance, we use a Epic, and we have like 90% like what their race is and ethnicity. So they were able to get a pretty good definition of like what these races were. But yes, it was based on the ICD codes that they were billing under. So if if this is for community acquired pneumonia, so if they billed for ventilator associated pneumonia, it wouldn't be that, or if it was some kind of, weird pneumonia, they wouldn't diagnose for that. Again, they didn't speculate on why Asian children or Hispanics would be more likely to be prescribed antibiotics if they were hospitalized with pneumonia. But they corrected for ICU admission, and and it didn't change. Like it was consistent across the board. So I didn't, maybe I could speculate, maybe there is by clinicians to perceive that they're from areas that have greater resistance. I mean, that's possible, but they don't really go into what are the drivers of this. So one thing that is a little bit better for Black, oh yeah, and I forgot to mention at the beginning, you told me to mention, if you have any questions, totally feel free to interrupt, ask me throughout while I'm going too. So for viral respiratory infections, so those infections, which we generally shouldn't be prescribing antibiotics, the clinicians don't prescribe Black or Hispanic kids as much. So around 50% less likely to prescribe Black children if they have a viral URI, and 35% for Hispanic children. So technically, this is a good thing because none of these people need antibiotics. But I think this is a reflection of what's happening. They're already tending to not prescribe them. It tends that really none of us should be getting antibiotics for viral upper respiratory infections. So this is one good thing that they're not getting as many antibiotics for those kind of infections. So I mentioned that all these studies are outpatient. This is the sole study that looked at inpatient data. And this is, to me, really intriguing. So they looked at people that were hospitalized with skin and soft tissue infection, so like a cellulitis. So our preferred treatment for that is most generally cefazolin. If they had a wound or MRSA, then vancomycin kind of treatment. So these white people, they were actually almost 3 times more likely to get guideline concordant treatment, which is ANSEF. But Black people were less likely to get ANSEF, and they were actually they were more likely to receive clindamycin, which is, it has really fallen out of favor. So just because of the side effects with C. diff and resistance and just not great, you know, strep coverage and stuff like that. So they really were getting a less preferred antibiotic compared to the white people that were getting hospitalized with the same condition. And so they also looked at, like, they corrected this to see they had their MRSA status. So certainly it didn't change once they corrected from, actually both groups had about the same degree of MRSA. They looked at penicillin and cephalosporin allergies. Both groups had the same amount of allergies. So it wasn't a reflection that there was more labeling for this group, that they couldn't get ANSEF. They had to give them this less preferred antibiotic. They just got this less preferred antibiotic. When I saw this, I was very surprised, because it's just like, I can't even, unless someone had a necrotizing infection, I can't even remember the last time I would give someone clindamycin for a cellulitis. So it's really interesting. And this actually sparked, kind of within my group at KU, to look into this to our own health system to see how are we prescribing within our facility, looking at things like this, skin and soft tissue infections, and also pneumonias, and as what we've started looking into. Another one that is somewhat interesting is bacteremia. So this was a study where they looked at the risk of Black and Hispanic people versus white, was the reference group, was white, compared to the risk for community-acquired bloodstream infections or hospital-associated bloodstream infections, and then also community onset or hospital-associated UTIs. And so they found that this was adults. Black adults were about a little bit over 1.5 times, 1.6 times increased risk of community-acquired bloodstream infection. So they're not getting this in the hospital. They're coming into the hospital already with this bloodstream infection. And so we might think, well, there's things that maybe made them more at risk of having that. Did they have a central line, or did they come from a facility or another healthcare exposure? But they actually corrected for that, and that didn't seem like it impacted the risk. It didn't really change it. They also looked at the number of central lines these people had. That didn't change. So they just, for some reason, have it increase. There was an increased risk of bloodstream infection. And then in the hospital, they had a 1.3 times increased risk of a hospital onset. So when they're in the hospital getting a bacteremia. They looked at, and they actually didn't find any differences for the white versus Hispanic. So those were the same for the bacteremias, actually. For UTIs, they also looked community onset versus hospital onset, and they found that the Hispanic adults were about just a little under 1.5 times greater risk of developing a UTI compared to the white reference group. And then Black adults were 1.5 times the risk for UTI, community onset UTI. So, again, none of these studies go into factors of why this is happening. This study actually did really correct for healthcare exposure, central lines, catheters. So they kind of did look into that a little bit, but the bulk of these really aren't getting any of the drivers of why this is occurring. This is just what it shows. And then what we've seen, also with COVID. So this was a study, a study amongst healthcare workers, and they looked at, different types of healthcare workers, and they found that Black healthcare workers reported they were about 18% less likely to get tested for COVID, and they were but 89% less interested in the vaccine. And then and this spoke to earlier when someone mentioned the research. So the Black healthcare workers were 51% less likely to be interested in entering a clinical trial. So, they're not getting represented in the literature as much. They're not participating, they're not being involved in it. And so their outcomes, are not being, reflected along with the entirety of what, is being studied. They looked at Hispanic too. Hispanic and Asian healthcare workers, they were also less likely to be tested. So they were actually about just a little under 25% less likely to be tested. But Hispanic healthcare workers were more likely to be diagnosed with COVID, so 23% more likely. And then also the Asian healthcare workers were not, they had a low interest in the vaccine also, so 52% less interest. This next one on the work impacts, I find very interesting. So the Black healthcare workers, they were about a third more likely to report 3 or more daily emotional impacts, but they were almost that same amount. They reported less likely to have burnout. So endorsing more daily stressors, but overall less likely to have burnout. And why I guess that, I mean, again, they don't really speculate on that in this study. This is just, on their responses and stuff. But are they having like a daily, degree of a threshold that's higher than everyone else or something like this? There's another study where they've looked at, so the Insight Council survey, and this was clinician, but it was also they looked at executive responses and clinic leader responses too. And they found that the clinicians, this was post COVID, so it was like in 2020 to 2022, I believe, is this Insight study. And so they found that actually clinicians, 49% of them reported interpersonal racism at work. So this is in the healthcare setting. About half of people are reporting that they're experiencing this at work. And then they felt like 47% of these respondents felt like it got worse throughout COVID. So half of people are experiencing racism, and about half of those same people are saying it seemed like during COVID or after COVID, it's only been exacerbated. And so the same true, we go back to pharma equity. So people getting access to treatments, so like Paxlovid or Marunavir. So you can see here by the different groups, how likely are they to get those treatments? And you can see certainly in the blue graph, white, they're the most likely to get the Paxlovid or the outpatient COVID treatments. And you can see at the bottom, the least likely Hispanic, followed by the Hispanic and Asian, or Black and Asian, sorry. So these studies looked at insurance status. They found that, possibly a little, it's unclear whether it's better or not, but they looked at Medicaid children specifically, or uninsured, and they found that those kids that are either on Medicaid or uninsured were 21% less likely to get any antibiotics. And so they didn't actually, this was, again, claims data. This was not indication. It was just generally prescription for antibiotics. So they tend to be prescribed less antibiotics. One thing that was actually a little bit better for Medicaid patients, so this is females with UTIs. They found that Medicaid females were more likely to get guideline concordant antibiotics compared to females that were privately insured. So and 35% more likely to get the right to get the right antibiotics if you're Medicaid. So whether this is a perception of the broad spectrum is more expensive, or whatever that is, again, these studies don't go into the reasons of it. That's like really, I think, the next step on figuring out what are these perceptions and why are these differences happening. And then this is also really interesting, the prescriber factors. So we're looking at the individual level, right? But like a couple studies have looked at the prescriber factors, and they found the highest prescribers, most inappropriate prescribers are older physicians. And specifically, one study called it out, and they actually said the best prescribers are born in the 1980s, and the worst prescribers are in the 1960s. Male clinicians pretty consistently tend to have higher prescribing. Um, Nurse practitioners and PAs a lot of studies tend to have higher prescribing. Pretty consistently, pediatric tends to be one of the better prescribers, and I think they've just gotten so attuned to getting requests for viral respiratory, and they've figured out how to have this conversation to, not prescribe antibiotics. Again, this study doesn't go into that. That's me speculating. The other one that prescribes pretty consistently pretty good is internal medicine. ENT, again, maybe they're seeing so many people that have these complaints all the time with like chronic sinusitis or respiratory conditions, that they've just gotten kind of like better at like having this conversation of like, you don't need any antibiotics, this is what you can do instead. The other group that prescribes actually pretty good, and I mean, I definitely see this too, as surgeons. And perhaps maybe that's because their visits are a lot shorter, and they might say, "You can go check with your PCV." I don't know. Again, speculation, but these are the specialties that tend to prescribe less. And then not just less, but they look at appropriateness. And so they tend to be more in alignment with like appropriate antibiotics. Um, and then, yeah, so basically those clinicians, like I mentioned, the people that are, it tends to be that closer you are to your training, the better that you're prescribing, basically. This one doesn't really go into it, but the next study kind of talks on it too. There's not been a study that actually looked at the distance from academia. But this next one, this was that Medicaid study. And so they actually found the this is Medicaid, kids with Medicaid, and they found the lowest rates of antibiotic prescribing was in the urban areas. So like Louisville was the lowest prescribing county. The highest prescribing county was clear on the eastern side. This one was 3 times higher. So they had 3,000 prescriptions per 1,000 population compared to Louisville had 1,000 antibiotics prescribed per 1,000 population. So pretty dramatic difference. And so they found that this study did actually look at the farther the distance from where the training centers are, the academic centers, the worse the prescribing is getting. So perhaps that might be, something that again, you're maybe more closer to educational sources, or maybe it's a younger group of clinicians. I'm not really sure. Again, they don't go into the fact, but that is something that tends to be found in some of these studies, is if you're out, not just rural, but if you're far out from the other areas of academia, there's a pretty big difference in what's prescribed there. They so another thing that I thought was really interesting in this study, so Ceftonir, it just like Ceftonir in general is just like not like, so I'm ID and I've never prescribed Ceftonir. It's just, you have better options. It's like the bioavailability is like bad. And so anyway, like, so we just never prescribed Ceftonir, but it's prescribed a lot. Like it's been like threefold increase in like the past decade. So it's like manufacturers like doing an awesome job with clinicians. So anyway, so Ceftonir use increased in this rural area by far more than it did in the urban area. So much so, by the end of the study period, the Ceftonir accounted for almost a third of total Medicaid antibiotic spending in Kentucky. A third of their antibiotic spending for Medicaid, just on a PO antibiotic, which is kind of crap. So, so this is something that we're kind of looking at in our state too. And I'll show you some data at the end that there is some differences in our state. We haven't looked specifically at Ceftonir. We've kind of broken it up by classes. They also, you can see here, they also mapped it over this time period by clinician type too. So the general practitioners, they decreased over that time period. You can see that in the black one. And then nurse practitioners in the orange, they really increased quite a bit over the same period. Uh, and actually I mislabeled that. That is so actually I labeled the bottom one NPs. That's actually pediatricians on the bottom. So they've stayed pretty stable. Or PAs is on the bottom, sorry. So the yellow is PAs, so they kind of held steady, but you can see the NPs really increased quite a bit over that period. So yeah, that was just the same. Oh, I didn't show it this. So this was that map where I said the highest prescription. So you can see 3,100 prescriptions per 1,000 populations in that rural area. Louisville was 1,000. So that's a dramatic difference, And then here's just kind of a map about that, the differences in the types of antibiotics that's being prescribed. So so amoxicillin was tending to have increases in rural, which like, hey, I think if you're going to prescribe anything, a narrow spectrum like amoxicillin, I think that's good. But the other things like the Ceftonir, they're far outpacing what is being used elsewhere. And I think, so we see these maps a lot where they looked at kind of the use, and it does always tend to be the southeast tends to have the highest prescribing. Um, so no surprise that when they looked at upper respiratory infections that they're prescribed more in the south. But actually, for when they looked at by race, they found that the I think, oh, this is Western. They found that the Western side compared to the South, so the Southeast side, they were 82% more likely to get prescribed the antibiotic. I mean, I don't know what goes on in the West, but they really do, like, even like Colorado too is really good. And then we get into like Nebraska, Kansas, Oklahoma, and then it just goes to shit or something, like it's really quite dramatic, how like why Colorado is so good. And like even you'll look at Western Kansas, I'll show you some maps. They have a lot of prescribing, more prescribing for some antibiotics compared to the eastern side of the state. So it's not just that it's out there. There's, I don't know if it's their academics. I really don't know the factor of why that has happens, but it's definitely a consistent finding. Yeah. Yeah, I mean, it could be. Because sometimes, oh yeah, let me repeat it. So the question was, might it be related to alternative? And I think where you see California, Oregon, Washington, Colorado, so you see that all being kind of low. But then you see like, I guess I don't think Montana being like super alternative, and that has the same amount, and so does like Nevada and Utah, and so perhaps I've thought that too. Maybe they're just tending to do more natural treatments or something like that. And I think that might be part of the answer, but definitely there's something else beyond that. This was so going back to that Insights Council survey. So this is those hospital executives and those clinic leaders, and then there are also clinicians. And so they felt throughout the pandemic that the pandemic tended to worsen their organization's ability to provide equitable healthcare. So almost half of respondents answered that. And then I mentioned that earlier one that about half of them say interpersonal racism is occurring at work in their organization. Um, Interestingly, I didn't really break this down, but the perceptions that the racism is getting worse it is perceived. It's answered to higher degree among the executives than the frontline clinicians. And that's for all of these kind of things that are perceived to be getting worse, the executives are rating it more strongly than the frontline clinician people are. And so this was just asking them, what are your top three areas of disparities in healthcare delivery that are most prevalent? Behavioral health, chronic conditions, and preventable hospitalization. So, probably not that surprising in that response. And then they asked also, like, what is your institution doing? What programs or commitments have you used to address disparities in care delivery? And so you can kind of see what the answers are. Or organizational commitment. I mean, I think we see a lot of that. But interpreter services, community outreach are high things that people responded to. Developed systems to measure these race or ethnicity or preferred language and residence of patients. So that's about a third of people responded that a third amount of hospitals responded they're starting to do that in some way. And then included social workers in the care, like what we just heard about, the community health workers, which is good. And then, less lower amount of health systems or hospitals are reporting the things on the bottom. So about 20-ish% are saying that they analyze or monitor those clinical outcomes, identifying programs for social needs, identifying the most effective way to assess and document the needs. I think this is changing because, as a lot of you are aware, there is now the CMS quality improvement that now is reporting the social determinants of health, which I'll talk about in a little bit. So again, this was like 2020 to 2022. And then this is my final slide on that Insight Council. How widespread are disparities in care delivery at your organization? And you can see about half of respondents answered either extremely widespread, widespread, or very widespread. About a third, a little over a third, said not very widespread. And then the other question was, to what degree are patients impacted by disparities in care delivery? And so about two-thirds answered that they were impacted by those, whether that be extremely impacted to very impacted. and only like 29% said not very impacted. And as I mentioned, higher amounts of the executives tended to answer those that they were very impacted than the frontline clinicians. So they're perhaps seeing something in their organization or their, their details that's different than perhaps, maybe they're getting reports and stuff like that, quality reports that the frontline clinicians aren't privy to. So what are some things that we can do to address this or start to think about this more on a system-wide basis? This is a really good paper that came out last year, and it was basically, how it's looking at how like we can improve this antibiotic prescribing, and also because like a lot of what I do is antibiotic stewardship, because that's another thing that is inequitable in rural areas. They don't have people that might have that micro or antibiotic expertise. They certainly don't have ID physicians. They may not have ID pharmacists, or they may not have people that have done specialized training to get more expertise that would be a good leader in those areas. So this is definitely another area of improvement, is trying to get better access to antibiotic stewardship, because we know those have better outcomes, and we know that they also save money generally, and they improve reduce rates of resistance. They also, another thing that we can start to consider in our stewardship is, to like look into more of these disparities. So I just showed you a lot of data about how the differences are, but not a single study has looked at perceptions of these providers to say, why would you have prescribed 25% less for this patient than this patient? So there's been no surveys that have looked at attitudes, perceptions of antibiotics and these types. There's been no looks at, those kind of markers. There's certainly, not like a biologic reason that they should be prescribed different. So this is another area where there is starting to be a little bit more work on these differences, but there is really no work on why this is happening for antibiotics, at least. And another factor too is increasing that diversity in decision-making roles. So, like I just said, like stewardship programs, perhaps like some programs that I've heard, it tends to be physician-led, or they won't have voting privileges to the nurses that are on the stewardship committee, or the pharmacists on the stewardship committee. Diversifying who is on the committee and allowing everyone to have their voice as well is another effort that we can do on the stewardship side of things. So this was the Joint Commission last year, where it's now recognized as a national patient safety goal. And so perhaps some of your institutions are starting to track the social determinants of health. So actually at KU, we had a social determinants work group that formed last year, like last summer, I believe. And so what they did, this was quality. I was on it, but I can't say that I can't say that I participated much rather than just listening to what they're doing. But I'm starting to use what they did now to try and incorporate into our stewardship program. But so quality, social workers, infection prevention, there were several infection preventionists, stewardship. So it was kind of a multidisciplinary team. But what we did at KU is they worked on this, developing the social determinants of health. So it started on one unit, so a single unit. Those intake nurses require these 5 social determinants questions. So the food insecurity, transportation, housing instability, interpersonal safety. They looked at utility needs or loss. And so those 5 things they tracked on every patient that was getting admitted, one unit. And then once they got that, they built that into the EMR and got that process pretty well, how they trained those nurses. It then went system-wide last winter. I think it was in December, it went system-wide. And so now in January, CMS is now requiring that submission of that social determinants data. So this is an example of kind of what that, so they've created, so again, I said, there is a lot of information now that they're using for that social determinants. I think earlier they mentioned that they found that on the cardiology unit that there was a certain the Black people had more rates of, I think, poor follow-up, and so they diverted more resources to that. Another one that really came out of this work, which really has only been going on a year, they actually found that readmission rate was most tied to transportation, which I guess seems pretty reasonable. If you don't have transport, it's like hard to make your follow-up visits. And so then you miss your follow-up visits and you're, having a chance of getting readmitted. But what they did actually, so they found that was such a correlation. And so they got more resources, the social workers, to do effort to address how post discharge, how are we going to get this access to transport? Are we going to give them vouchers, or how are we going to get them to their appointment? So that was part of the discharge planning, and it stemmed out of the social determinants effort that they did. And so you can see here, well, it's pretty small, but this is kind of the dashboard that they created. Yeah, go ahead. Hmm. Hmm. S Yeah, no, so not every no, no, no. So they are asking all of those questions, all those 5, but they don't have initiatives for every of them. So if there is a food insecurity, so again, you ask a question, and, like, if you answer that you are food insecure, there's not an initiative for that yet. The one that they've found, because they found that it was the biggest association with readmissions, is the transport one. So yes, and that is the effort that they have started working on, probably the most system wide. But if there's a domestic abuse response, I'm not aware yet that there's like a full strategy. Like a system wide strategy to address this for every patient that answers a positive for every single question. Oh, yeah, yeah. Sorry. The question was, so on the intake, the nurses are asking all these questions. If there's a positive for each of those, is there a response, and is there enough, like, social workers to be able to address these? And so that was kind of, yeah, not definitely at this point, not enough resources to be able to answer every single one of those. And it is like, it's like, again, you do ask these questions, and when they're yes, it's like, kinda, like, what do you feel helpless, and so it kind of puts you in a, but, I mean, we won't find out how to develop these programs unless we know, of course. So, yeah, they had, like, again, we're like a Vizient, so they've created this dashboard, and so you can go and see over time, what are, if anyone wants to look at it, what are the amount of people without experiencing homelessness, or, food, insecurity, or et cetera. And so, obviously a big one that we do have is homelessness. And so we've built that, we've used that as a result of this. We're actually going to use that social determinant to work to piggyback onto another quality improvement project that I'll talk about in a couple minutes. And we formed in stewardship, our stewardship committee. We formed a health equity stewardship task force. So this is two ID faculty, so me and another one. We have an ID fellow. She's actually a she did a master's in ethics too. So she is a really, yeah. So she's really great. Fellow to be on this, and she's actually now on the Shea diversity inclusion program, also the task force for that. So she has a really interesting perspective. We have one ID pharmacist that joined it. We have two ambulatory pharmacists, and then we also have a nurse. And our nurse, this is more like an outpatient nurse, and she's awesome too. So she really has spearheaded a lot of things in our own clinic, which really isn't a system wide thing. It's just been our clinic where, her husband works at Harvesters. And so we have, we ask everyone in just our own clinic, like, do you need, are you feeling like you need access to food or whatever? And so we have that in clinic, that we've been providing that for years. But because she's had that experience and she's been able to do that in clinic, she has a great perspective for the bigger how we can do this on a bigger level, basically, not just for one tiny clinic, but spread the efforts to other clinics and other parts of the hospital. So what we're starting out with looking is, as I mentioned, there was only that one study looked at that skin infection. And so since we saw that, there is a lot more literature on the outpatient side, we decided we're going to look on the inpatient side and see what kind is there differences in prescribing. I think, this actually is not as hard to look into your EMR as we initially thought. Um, Especially now where they are reporting like the social determinants of health too. That's way a really you can get a lot more details. And I think there was something like 90-ish% of our only 10% of them has like something like for race and ethnicity, for example. There's like a prefer not to answer or unknown. So the really like 90% of people are reporting some response. So we're looking at community acquired pneumonia because we talked about a lot of different conditions. We didn't want a condition that has a lot of variability in prescribing, like UTIs. That could be pretty, diverse population of people with recurrent UTIs and drug-resistant infections. So what is something that's fairly consistent? There's not a lot of variability that you would prescribe for like guidelines. So we thought community acquired pneumonia would be a good one to look at. And we're looking if there's a difference in the type of antibiotics that's being prescribed for these people that are being admitted, the durations of antibiotics, the discharge antibiotics. So on discharge, are they getting different PO regimens than by different kind of demographics? We are looking by race, ethnicity, gender, the age, extremes of age. Like I mentioned, there's some literature around that. We're just looking at age, see if there's a difference. Insurance status also. And then we actually can look at the social vulnerability index within our system because their address is on it. So within, at least through the EPIC side of things, it does have a social vulnerability index that you can map. And even if you didn't have an EPIC, we have a data person that was like, yeah, you really don't even need to use it that way. You can actually just use it because it's always their address is all for the most part going to be on their, their for their insurance and stuff like that, or their when they check in or whatever. And then, as I mentioned, since there's prescriber type differences, we are going to try to look at specialty and possibly age. We're not sure if we can get this yet. I think we might be able, I know definitely we can get the specialty, but the age is one that we're trying to figure out. If the Kansas Board of Healing Arts does actually have some fairly detailed demographics. So that plus or minus if we can figure out the age, but that would be very interesting if we could. Yeah. So, yeah, the question was what kind of information is in the social vulnerability index? The social vulnerability index or SVI, that actually comes out of what the CDC publishes, and that's based on the address. And so there's different kinds of indexes. There's medically, their degree of medical underserved. It's their income level. So it's kind of maps it per these different regions. And so that's what we were looking at to see, based on that, if we can see any type of prescribing difference. So I mentioned that we did start using the social determinants work that they're doing, and so because there has been in recent years increased cases of hepatitis A in both Kansas and Missouri side, we thought that hey, this might be an opportunity to use that information for those people that are exposed, like are homeless at increased risk of hepatitis A, to have kind of an increased initiative to get them vaccinated against hepatitis A. So we've kind of incorporated that into a vaccination kind of QI project that we've been working on. And then I was going to shift gears and talk about, so from a statewide level, certainly our state, as we hear about, about, is because of the nature of our hospitals. This is just generally we are at risk of unequal antibiotic stewardship, antibiotic health equity impacts. But as it pertains to stewardship, we've definitely seen this over the years. So 5 years ago, we ranked eighth from last nationally with the core for the antibiotic stewardship programs. We actually have made quite a bit of headway. So I think now we're like 39, 39th, I believe, or yeah, 49th or something like that. But we're not 49th, 39th. So we have made some improvements in that, and there definitely over time has been improvements in, accountability and programs being committed and stuff like that. But this is something too that we think from the state level. How can we reduce some of these inequities? Because we have access to ID expertise. So me and there's also an ID pharmacist that works with me at KDHE. We are the co-leads for the program. How can we provide clinicians with those things that they don't have access to? So for instance, we developed a state antibiogram, just working on redoing an update of it. And it's broken down by region because, I don't think that, like where I'm from, Northwest Kansas, is, vastly different than the Northeast side. And so is there a difference in antibiotic prescribe or antibiotic resistance per region? And the clinicians there, so I've collected over 60 antibiograms. It was the same, I did it in 2020 also. And most of these hospitals aren't doing antibiograms. What they submit to data to me is just the micro data, and then I put it in and form the antibiogram. Some of them really do have really good antibiograms in these smaller critical access hospitals, but they might have only 30, isolates or something. So it's not like you don't know how like representative that would be versus the antibiogram for E. coli has 20,000 isolates in our state. And, in Northwest Kansas, we have like 6,000. So it's something that can provide them if they don't have access to form their own antibiogram. Here's one that's of the state, and specifically for when we have enough isolates, here's yours for your region so that you can develop your own guidelines based on what we're seeing in our state. We've done a lot of stuff for developing policy templates on like these things for guidelines, and it's adapted to what we're seeing here resistance wise. And then just, doing a lot of things in the rural hospitals, how we can provide assistance, because all these things, the IT support, clinical decision support, all these things, they might not have as much access as we do, or how we can navigate the system as much as they would in the smaller hospitals. And I will say too, there, no, again, really nothing on the drivers. This is the the PACCARB, so the Presidential Strategy for Combating Antibiotic Resistant. And they actually last year in their work plan, so they kind of make like policy recommendations as it pertains to antibiotic use, stewardship, antibiotic resistance. So the last report that they formed last year, they actually did recommend, you can see it's kind of small here, you can't see, but actually they did include as something that they recommend that hospitals do start looking into, how, the differences in prescribing, and also not just that, but the stewardship program for these rural smaller hospitals or resource limited places. Um, okay, so here's some maps. So prelim, so draft. So we're still working on it, but these are some of the rates. Like I mentioned, there is quite a bit of variability in our state. This one is fluoroquinolone. So this is going to be your levofloxacin, moxifloxacin, and ciprofloxacin. And you can see, so we mapped it, where's the highest prescribing? And actually in the western side of our state, there was a lot more prescribing. You can see there around 50 prescriptions per 1,000 populations. You move over to the northeast side, 24 prescriptions per 1,000 population. So really variable differences. We also looked in the degree of like how rural it was, if it was frontier, urban, semi-urban. And we found that like it wasn't the extremes. It was those that were more in the middle that were prescribing the most fluoroquinolones. And then the one on the bottom is the change. So 2019 to 2021. And you can see that it does tend to be on the west too, that the ones that are the counties that are in red, they're getting more prescribing versus the one the greens are getting better. So when you see those counties, you see where are they starting to prescribe even more. This is for macrolides. Again, the western side tends to have the highest prescribing of macrolides as well. So this kind of mirrored the fluoroquinolones essentially. But again, they had a lot more prescribing than the eastern part of the state. We're talking 70, 75 versus northeast was 40, versus north central was 31. And this was actually, so I didn't really mention where this antibiotic use data comes from. This represents all outpatient, not all, but 95%, around 90% of outpatient prescribing. We got it from a data source called IQVIA. And so even like mail order pharmacy, VA pharmacy, so this is this is like millions of prescriptions. So there was a lot of difference in the macrolides too. The this is the sulfa, so Bactrim, generally speaking. So similarly, it's kind of that urban, it's higher use in urban, semi-urban. But then it's not exactly the same for this one. There was a little bit interestingly more in South Central, and then again Southwest had higher, but the Northwest wasn't prescribing this as much. And then you can see kind of there in the bottom the counties that were starting to prescribe more over time from 2019 to 2021. Again, that does look like this data doesn't have it, but it is on the western side where their rates are increasing. So they are tending to, maybe like the eastern part of the state is starting to have a turnaround in their prescribing habits versus the west seems like it's not following that trajectory the same. So we're looking into that data and we're going to pull it also by specialty class. And we even have data for dentists, podiatrists, so non-medical professions, and even veterinarians too. But that's not that comprehensive because they have their own dispensary a lot of times. We're looking into antibiotic classes, so we're going to see, is there an increase in septicemia in certain areas, and are they disproportionately occurring in some areas more than others? And then, of course, we're going to look in the rural and the urban. This is another kind of information we've been working on, and actually, this is going out not this month because we're in November. So U.S. Antibiotic Awareness Week is in a couple weeks or 3 weeks, and so we are sending these out to clinicians or prescribers. And so this map represents this is a totally different data set, but it's from also IQVIA. So claims data for viral respiratory conditions, so viral pharyngitis, flu, viral pneumonia. These are the kind of ICD codes that we used. And then they're associated with an antibiotic prescription. So conditions that generally wouldn't be getting an antibiotic. And you can see here the darker orange are the ones that have the highest, the fourth quartile. So the most inappropriate prescribing versus the light blue is those that have the least. We've had to do this very politically, so like saying, it's not wrong antibiotics, but like most inappropriate ones. So anyway, we sent out an intro letter over the summer via email. And again, we got this information from the Kansas Board of Healing Arts via emails because we do submit that in our license. Some of them are their practice manager. They're not maybe their individual license. So a big effort has been, what is this your address, your correct email address? So I think is like 9,000 providers. And we've actually gotten a really small amount of bounce backs. And so now after we spent months trying to sort that out, we're in the final stages of getting this detail to send them out. We did this kind of a couple years ago, and we got feedback so for instance, I heard back from I think it was maybe it's pediatricians or ER, and they didn't want to be compared to like surgeons, or they don't want to be compared to not like whatever their specialty was. And so this time we broke it down and we compared family medicine to family medicine, internal medicine to internal medicine, like ER to ER, like those kind of comparisons. And then we did also like a whole, like how you're comparing to everyone as a whole. And then also PAs to PAs, nurse practitioners to nurse practitioners. So yes, this should be coming out in the next week, 2 weeks. And then we are looking into that data to buy different kinds of, again, these types of antibiotics or the different types of providers, the different kind of regions, et cetera, and seeing what kind of trends are out there. The other thing that we've been working on, and I don't know how many of you were in Tessa's presentation was really interesting, is these pharmacy deserts and trying to start characterizing this a little bit more. So those areas that are the greatest risk in the urban settings, those areas that do fall into the social vulnerability, high index of medically underserved areas, or those areas in rural areas that are going to lose their access to vaccines, so that's what we were talking about afterwards, is we rely on the retail pharmacy now to do most of our vaccines. So when all they shut down, what is going to happen to all these vaccine needs that we've kind of shifted from the clinic or the health department to the pharmacy? And then also the workforce, characterizing this kind of workforce. And so like this kind of stemmed out of looking into the types of antibiotic that were being prescribed as like an auditing project, but finding out that really like there was a lot of pressures, dissatisfaction about the scope of practice or about the not having enough tech assistance to do these, like I have to do 100 vaccines today in addition to answer the phone and I have to dispense a med, like so that's kind of we have the School of Pharmacy faculty and some pharmacy students that are interested in working on that.